So now we've talked about 5 monogenetic disorders for ischemic stroke. There also are monogenetic disorders for hemorrhagic stroke. This is the most common one. Cerebral cavernous malformations usually don't present with stroke, but more often with seizures, can present with focal findings due to hemorrhage or simply due to mass effect. I'm going to talk a little bit about HHT. In a study we're going to talk about, hereditary cerebral amyloid angiopathy was screened for. That's a disease where you have increased incidence of cerebral white matter changes and hemorrhages. There's several different genetic mutations occurring in different countries with slightly different presentations. How about hereditary hemorrhagic telangiectasia? So these are patients who will have very small and numerous telangiectasias on their skin. You can see them under their eyes. You can see them on their face, okay? These people come in with episodic nosebleeds, okay? Recurrent nosebleeds, severe nosebleeds. They can have, iron deficiency anemia because these can occur in the gut. The reason to recognize this kind of skin phenomenon, okay, is that, as described by Osler, Weber, and Rondeau, as I said, even before the understanding of the genetic basis, they understood this was an autosomal dominant. These patients can have arteriovenous malformations. And so knowing and recognizing that patients with this skin issue potentially should be screened for this disorder, especially if there's a family history of hemorrhagic stroke. If you treat these arteriovenous malformations before they rupture, the mortality and morbidity is much less. So now we talked about how monogenetic disorders are inherited. We talked about the challenges of recognizing them. Really the key question is, why is it worth my time to come and talk about this? Why should you guys try to remember anything about this lecture? Will this somehow contribute to patient outcome improvements, family outcome improvements? How can we try to really screen for what's important here? We mentioned, as I was talking about each one of the disorders, why it is important to think about them, because of aortic screening and aggressive hypertension control in patients with Marfan's. Ehlers-Danlos, same thing, plus avoidance of things which would cause dissections in their vessels. Enzyme replacement therapy. In MELAS, there are empiric clinical trials which show that incredibly high dose PO arginine or PO citrulline, and during an acute stroke episode, within the first few minutes and hours, treatment with IV arginine, okay, can improve outcomes, okay? So, and there's ongoing clinical trials in MELAS. We'd like to identify more families, potentially to send them to teach us more about this disease. And in CADASIL, perhaps telling us something else that will help the family. Because beyond what's happening today with that patient, if you do make this diagnosis, the benefit can reach out in other ways, not only for that patient, but to other people in the family. So one thing is, especially if there's a family, for example, CADASIL families where they actually knew they had a genetic disease, or they knew they had some familial disease, because that was something that they themselves had noticed. Sometimes you can share prognostic information. Unfortunately, because of variable penetrance and the heteroplasmy we talked about in MELAS, you can't always know exactly what's going to happen, but you can, offer them the opportunity for familial genetic testing. For example, in an X-linked disorder like Anderson-Fabry's disease, right? So if a man who has that disease has children, okay, the disease is on the X chromosome. So he cannot, none of his sons will ever manifest the disease. He gives them the Y chromosome. Now his daughters, half of them will be carriers, and half of their sons may be symptomatic, okay? But understanding how that works through the family can be helpful as the family makes plans. And one of the most important things is, even if you don't diagnose exactly what the mutation is, if you see someone with large ectatic vessels, dolichoectasia, and enlarged aortic arch, and you don't know what that is, okay? Maybe these people haven't even had strokes. Maybe they're like one of my patients whose aortic arch was operated on 3 times within a 3-month period, essentially Dacon grafted the whole aortic arch. I said to her, well, did anyone say maybe this might be genetic? She said, well, they tested me for Marfan syndrome. They said I don't have that. So, well, that's great, but what about your children? What do their aortas look like? Any interest in taking a look at their aortas? I have a lot of interest of taking a look at their aortas. Whether I ever exactly diagnose what she has or not, it makes me think about ways I could potentially help her family. And as we understand, and there is now over 200 monogenetic disorders in low frequency, often associated with a lot of other diseases and physical findings. Each one of these potentially in the future may help us understand a little bit more about this. Now, as we think about how do we screen, you say, well, you know what? Just give me a little formula and I'll go out and I'll start looking for these patients. And we got those genetic testing, Athena, right? Athena diagnostic testing. We'll send blood. It won't be too long before we'll just have a little chip, right? You'll draw blood. You'll just send it off. We'll know all about this. The answer is, unfortunately, not quite that simple, okay? So one of the cautionary tales here is inherited thrombophilia. 30 years ago, it was noted that some patients with young stroke of unknown cause had protein C, protein S, or antithrombin 3 deficiencies, okay? And now, routinely almost, patients who have a young stroke, or even some older patients, are getting screening tests for these disorders. In fact, it's not clear that adult arterial stroke is associated with disorders. They are important in pediatric stroke. They are definitely important in venous thromboembolic disease. So if someone has a cerebral venous sinus thrombosis or a family history or personal history of DVT, you want to screen for these. But not as clear that everybody needs to have these if there's no history of other venous thromboembolic disease. There is some evidence that factor V Leiden and perhaps prothrombin gene may be associated with an increased risk of arterial stroke, quite modest. These are very common mutations. If everybody who had those had strokes, we'd see a lot more strokes. So it clearly can't be the single gene thing that's causing their stroke. There must be many other influences. So who are we recommending? Cryptogenic strokes in young adults, okay? And specifically asking about family members who also have premature stroke or venous thromboembolic disease. And these are not just my opinion, but American Heart Association and Consensus Stroke Guidelines from 2014. Other reason we're not recommending screening these people, because we're not sure but also what do we do with it? It's not clear. If someone just had a single stroke and they're factor V Leiden positive and they've never had anything else, and it's not a paradoxical embolism, it's not a DVT crossing to a PFO, okay? It's just a garden variety arterial stroke. Should we be anticoagulating them? We don't really know. There is not data showing that that's an advantage for these patients. In the limited studies we have, these seem to be equivalent unless there's some other evidence of thromboembolic disease. So we're actually recommending antiplatelet treatment. So knowing what they have, again, may not help you treatment-wise. So what about some strategies? People have been thinking about this. Each one of these disorders is rare, okay? But they do have clinical implications. So is there some way that we can devise a clinical algorithm that will let us know who we should actually send for genetic testing? So this is hot off the presses attempt in the region of Lombardy and in northern Italy to look for 5 different disorders. They looked at 11,000 stroke patients of all ages, and they said, we're going to try to get a population, the 253, who we think might have a high risk of having genetic disease, okay? So they had a variety of criteria. If you want to look at their methods paper, it's actually quite sophisticated. They asked many, many clinical questions about some of the physical findings that I talked about in the other pieces of the slide to devise this. Out of all this, they had 253 suspected. They looked for specific algorithms, diseases. They screened people for 227 people for tests. And this is what they found out. Out of all the people they screened, 9, 10, 11, 12, 13, 14, 15. 15 out of 253 came back positive. So I think they were, frankly, a little bit disappointed by this. You can see there's a very low number, so it's hard to make much out of these percentage of people tested positive. Note that the most common one was Marfan's and MELAS, perhaps because this is the easiest one for us to recognize, and this is probably relatively common. So not exactly what we would have hoped for in terms of a clear algorithm that we can come up with. And I don't think we're going to have a chip that's going to be coming out that will be run for $100 or even $2,000, because genetic testing, how many people have ever sent someone for genetic testing for a disorder? Just a couple? I mean, very expensive, right? and there's a panel, there's 4 or 5 things in it, there's not 100 diseases in it. So some insurance companies actually will not pay for the testing. For example, MELAS testing, if you're thinking MELAS, send that in the hospital before the patient goes home, because the approval process is quite challenging. So just in closing here, I want to say, well, you know, how do I think about this as a clinician? What would I like people to kind of bring home and back with them that might be clinically relevant for themselves and the patients? So what I would say is, think about the unusual things. We know it won't be every single family member will have the same thing, but look at things that are unusual. The patient who presents with stroke but also has encephalopathy and unclear lactic acidosis, think MELAS. Someone who has the onset of stroke symptoms but they spread over 35 minutes and they've had multiple episodes, and you're thinking perhaps about familial hemiplegic migraine. An unusual presentation. Ask about the family history. Don't just say, anyone else have strokes? Ask each individual family member, alive, dead, date of death. And if you see people in there who are dying early, or they have diseases, as the ones I've talked about, aortic rupture, organ rupture, hemorrhagic strokes, ischemic strokes, ask for the age of onset, because early onset disease in multi-organ systems can be helpful. Look at patients, right? If someone looks a little bit unusual, and their families looks a little bit unusual, we're not discriminating against them. We're trying to understand, you know, what this might be a manifestation of that might have important clinical implications for the family. On the imaging and diagnostic studies, we talked about how sometimes that can be a clue. And also the disease course. We talked about how in MELAS, someone looks like they're having a huge disabling stroke. 3 weeks later, they're back to normal again. Okay? Someone looks like they've had a tiny little lacoon, but they have a ton of white matter disease and a lot of cognitive dementia symptoms, early executive dysfunction. Things that are out of proportion are just not right in terms of the disease course. And remember that these people can have risk factors. For example, in CADASIL, okay, it's an autosomal dominant arteriopathy. It's been shown that cigarette smoking and hypertension significantly increase the chance that the patient will become symptomatic. So yes, if someone has no risk factors, I think we all will say, genetics, that's kind of odd, no risk factors. But even in people who have risk factors, MELAS, diabetes is part of MELAS, okay? All right? So even in people with risk factors, that does not rule out the absence of genetic disease. There's wonderful online resources about this. You can, online Mendelian inheritance in man, very easy to search. You can put in different clinical symptoms. If you have an unusual physical finding, you're struggling with how to describe that, there's a nice pictorial atlas that will give you a concept of maybe what term you should be searching under, because what is this physical finding called? And as we said earlier, the online educational series about genomics and translational biopsy, we will be hearing about this. We're actually further along in genomics in many other diseases than we are in stroke, so it's something that's going to have more and more implications for us. Okay, so I hope everyone has maybe a little something to take home with this from this lecture today. I'd be happy to answer questions. I guess I would want to just say one more thing, which is to say, do not think when you think genetics that you have to identify what the disorder is. Even as a stroke neurologist with experience in genetics, I work very closely with the adult genetics clinic at University of Maryland. Marfan's has a movement disorder clinic, Marfan's center at Hopkins, right? So the suspicion just has to be there, and as opposed to pulling out those expensive tests or spending 5 hours on Amen, not if you don't want to do that's fine, but think about potentially referring these patients to an adult genetics clinic to actually, they will then know all these many phenotypes, many things, more the experts, they can do a more targeted testing, and more importantly, they can do the family counseling that should occur prior to genetic testing being done. If I have someone who has MELAS and I want to know, because this is going to change their management, I don't hesitate to send off the genetic test. But if I see someone who had 2 strokes in the past 5 years and I'm thinking CADASIL, this is going to have implications not only for them but for their whole family. And it doesn't have an immediate implication for that patient because there is no treatment for CADASIL. So I actually, as I think about this, bring the family in, start talking to them about the testing before I send it, even send them for genetic counseling before I send it, so they don't get frightened or see incorrect things on the internet, because it is complex even for healthcare professionals, let alone for patients and families, being told the frightening news, you have a genetic disease. Thank you.